Hello everyone. Uh, we are here today with the Bharat Dental Show with none other than Dr. Shaili Mehta. A warm welcome to you, ma'am. Let's know a little more about her. Dr. Shaili is an accomplished endodontist and aesthetic dentist with a passion for clinical excellence, education, and innovation in dentistry. She has completed her BDS from prestigious MGM Dental College and has done her MDS in conservative dentistry and endodontics from Government Dental College, Mumbai. Despite being early in her career, Dr. Mehta has established herself as an accomplished academician and a speaker. She has delivered over 25 guest lectures and has been featured in several online and offline podcasts and webinars and is an invited speaker at IAACD Goa 2026. Her academic journey has been marked by 23 competitive awards, including 10 during her BDS and 13 during her master's degree, along with multiple Best Paper and Best Poster Presentation awards across national conferences. Her achievements have been recognized with prestigious honors, including the Pierre Forscher Award, IACDE Clinical Excellence Award 2024, IES Endocase Contest Award 2024, IAACD Pan India Paper Presentation Award 2022, Young Professional in Practice Award by Dental Spotlight that was in 2025. She is also the youngest fellow of Style Italiano Endodontics from India, which is a prestigious chip on her shoulder for sure. Today, Dr. Mehta runs the Dental Dream, an exclusive microscopic endodontic practice in Bashi, Navi Mumbai, where she combines advanced technology with evidence-based dentistry to deliver precise, patient-centered care. She is deeply passionate about mentoring young dentists, advancing endodontics, and making quality dental care more accessible through education and innovation. So, yes, a very warm welcome to the speaker here this morning.
Thank
So,
you so
now we
much.
all know, yeah. We all know that composite restorations have transformed modern dentistry like nothing else. But in mastering composites, is it simply about learning a technique, or is it there a roadmap to which one can, work onto to get predictable, repeated, and highly aesthetic results? So, why do you think, Dr. Shelley, that composite restorations have become such an important part of modern dentistry?
So earlier, when we look at composite dentistry, it was seen more of a restorative material. Only, a patient comes and you do a quick filling, they come with decay. But now, because of modern composites and the technology that we have, so we are using composites for FMRs, we are giving composite crowns, obviously indirect composite crowns. But now the horizon of composite has expanded so much that moving from a simple class one filling, now we are able to restore entire full mouth case just with the help of composites. That's definitely because advancement in the technology and the research that has been going on. So it's very important for us nowadays to learn about composites because this is something that was not taught to us during college days. Like when I was in
Absolutely.
college, maximum of like my entire knowledge based in cons and endo was based on amalgam. So there's definitely a learning curve that we have to do after we are coming out of the college.
That's
Absolutely.
very nice. Very well put together. So now dentist actually is not just a doctor. They are artists as well. So it's a perfect blend of art and science, right? So Dr. Shelley, so if a young dentist wants to become really good at composite, where should they start from?
So when we talk about composite dentistry, unlike other fields, you don't really need a patient. You can basically start on an extracted teeth. What you have to understand is most of us are running behind understanding the shade, A1, A2, whatever. But most of us are failing to understand the different opacities and translucencies. And that's what makes a difference. So whenever you have an extracted tooth, it's going to, we all know that extracted teeth are dehydrated and it looks more white. But why does it look more white? Because it has more opaque. So if you want to start with your journey, start with extracted teeth first. Don't start with anterior because it could be disheartening. Start with simple class 1 posteriors and master the anatomy, master the shade matching, and then it's how you progress. Another thing that I would like to advise young dentists is that they attend random courses. So they attend 10 different courses, 10 different mentors. My advice would be stick to one mentor in the beginning, because every mentor has a different technique. I might be having a different technique. You might be having a different technique. What works for you, but the same thing might not work for someone else. So stick to one mentor for the basic things. After you master the basic thing, then sky's the limit. You can change your mentors, do whatever you want. Initially, don't attend too many complex courses. That will dishearten you, because you will compare your cases with the mentor's case without realizing there's a 10-15 year gap between your practices. So your work might be at an initial level, you might be doing good, but if you're comparing it to someone else who's been doing it for 10 years, you might not be happy. So if you want to start your composite journey, start with extracted tooth, start with a mentor, and start reading. One thing we do is we consider dentistry to be a very mechanical thing. We don't read about a lot of things, especially bonding. New generations of bonding agents are literally coming every day. So we need to understand all these aspects and start studying along with it.
Very, very well said. Because unless you know the subject, theoretically understand the knowledge behind it, you really can't implement it clinically. It makes sense. So, also, I'd like to understand what are the fundamental principles a dentist should master before moving to advanced composite cases.
So I think what thing that was ignored in our undergraduation days was carving, dental anatomy. So I was someone who was not excellent at carving and all. This is something I learned over these years. So your dental anatomy. Second, as said, we all know about the shades A1, A2, but we need to know what translucency fits where. If you have a very translucent enamel, a translucent composite, going to look darker. If you do the entire restoration probably with an enamel shade, it's going to look very dark. Even if your shade was A2, but if instead of a A2 denting, you use A2 enamel, your restoration is going to be completely gray. So understanding these aspects is important. Third thing, as I said, don't go into very complex casing. Don't go into angle fractures and layering in the beginning. Go with simple class ones, master your anatomy, then move to class twos, and then gradually start with your simple class three, especially from the palatal aspect. Then you can move on to complex cases.
So, is there any routine steps that you need to follow if we have to master the basic composite restorations?
So the first thing, which is again a very integral part of any form of composite restoration, anterior or posterior, is rubber dam isolation. So I mean, whenever we talk about composite, it's impossible to talk about only composite without talking about rubber dam. So rubber dam is the first thing that you need to master, and especially I've been taking courses for rubber dam, and trust me, anterior rubber dam isolation is very easy, especially when you are using the clampless techniques. You literally don't even need any clamps to put on your rubber dam. Initially it's going to be difficult, but later on it becomes very easy. After that, understand your etching technique. Every layer of tooth, enamel has a different behavior to etching, dentine has a different behavior. The same goes for bonding. We are so focused on matching our shades that we actually forget the bonding protocols, which is the more your composite is going to fail, or this patient is going to have sensitivity if your bonding protocol is not right. So focusing on rubber dam isolation, your etching, bonding, which generation of bonding agent to use where, is not dependent on what the MR person from a particular company has told you. It's a science based evidence which you need to read. So your fifth generation has a different application, your seventh generation has a completely different application. So understand where what type of bonding agent goes. And third thing and the last thing is doing a very artistic work. Now a lot of young kids come and ask that I want to do staining because I've seen this post on Style Italiano, they have done stainings and all. You need staining. The patient does not need staining. You want to give a perfect anatomy because you want to post it on social media, not because the patient wants it. If you give a perfect anatomy to the patient and the adjacent teeth are treated, your composite is going to fail. The patient is going to chip off that composite within about 6 months or a year. So understand the anatomy, understand the occlusion, how the patient is biting. Is the patient having any parafunction? So these things are something to be considered. Now, when I'm saying this, if a young dentist is hearing this, it's going to be overwhelming for them. Like, these things no one taught them. What we were taught in colleges, there's a class one, you excavate, etch, bond, composite, done. So don't run behind mastering the artistic way of dentistry. We want something that lasts long rather than something that looks beautiful and is a waste after 6 months. So focus on the
Yes.
science part of it. The art comes on its own.
So if we practice a fixed routine in a day-to-day basis, you will be expert at the end of the
Yes.
practice, right? That is what you want to say? Correct. So, does case selection play an important role? Should composite be the choice of restoration for every patient? And which cases are ideal for composite restorations? Can you please let us know, Dr. Shaili?
So as a continuation of what I said in the previous section was that diagnosis, especially the patient's bite or any parafunction, plays a very important role. We have to understand that I loving composite, I know that it is much weaker than a porcelain. But in a case where the patient is very young, you don't want to do any amount of enamel where grinding or anything, composites becomes a go-to material. Second mistake I've seen a lot of social media posts is also, I'm a Gen Z, so we obviously are in a lot of social media things. So I've seen a lot of people do composites on discolored teeth without anterior discolored teeth without even understanding the etiology. The tooth is definitely necrotic. There can be calcification. There even could be a cyst. So diagnose your problem. Don't just because you can do something, don't do it. Diagnose the case. Composite is definitely not the solution for everything in this world. It's a very comprehensive thing. So if you are a beginner, I would suggest to start learning about occlusion more. Simple way of doing it, if you have to restore a class 1, just look at 7 and 8 or probably 5 and see the wear pattern. If it's highly attrited, probably the chances are the composite is going to wear off. You have to just inform your patient that this is the thing. You can't give very sharp anatomies because under rubber dam isolation you will give excellent anatomies. The moment you remove your rubber dam, so when we talk about when I'm restoring a class one, I am on a lower six. So look at the wear patterns of 7 and 5. If you have applied rubber dam, you might give excellent anatomies. The moment you remove your rubber dam, you use articulating paper, you'll realize you have to grind a lot. You ultimately have a fat composite. So why waste time? Your time, patient's time, material, everything. Second, if you have done, you are doing an angle fracture and the patient has come to you saying that they got it restored 3, 4 times, but it keeps fracturing. Don't jump into just going there and restoring the tooth. Understand if the patient is telling you it's broken 3, 4 times, 3, 4 dentists cannot make the same mistake. There's some problem in the bite. So realize why the bite is breaking, for why the composite is breaking, correct that, and then move on to your composite restorations. All said and done, it is a fact that composite restoration need polishing after 2 to 3 years. So permanent solution could in the future obviously be a porcelain veneer, but you have to give the options. Sometimes it has happened that the patient has done composite restoration, it has lasted for 5 years. The patient's so happy with the diastema closure that the patient comes and says that I now want a composite veneer. So it's a good point for you to convert your patient. So now if you do a composite restoration, you're not confident about porcelain veneers. So you can start with your composite restoration, patient is happy, and now they want something better that's going to last long. So composite, I think, is not the definite solution, but obviously a very good solution to a lot of problems, and maybe a bridge between your porcelain, anything, only veneers, everything, and your full mouth rehab. So it's like a connecting link, and it's very safe because you do. In case you're doing a composite veneer, you're not removing any tooth structure. So it's a very safe game to play when we talk about composites.
Well said. And also, I think it becomes very time effective when patient cannot wait till the lab work comes in, then you do the porcelain
Yes.
part of it. I think that wins over there in most of the cases. Having said that, it brings me to the next question. What is that one case selection mistake that the beginners commonly make? Because, as you said, that not all cases are good for it. So, yes, just
Yes.
throw some light on this.
I think the biggest thing, the first and the most important thing anyone is supposed to ask, irrespective of what they are doing in composite, is to ask whether the patient has sensitivity or not. If the patient has pre-existing sensitivity, your entire treatment protocol changes. You have to do immediate dentine sealing, your bonding agent changes, your time of etching changes, everything changes. So people don't ask that. If it's a class 5, they have learned a random Instagram course or actual course and they want to just restore a class 5 without understanding the etiology, either the class 5 is going to fracture or the patient's going to have extreme sensitivity. So this is one mistake people usually make. Evaluate the case. See whether you have enamel dentine. How is the dent?
Excellent.
That's true, Dr. Shelley. Can you take us through your basic workflow for a composite restoration?
Okay, so in my care practice, if I have a patient coming in with an angle fracture, for example, that's I think the most advanced form of composite restoration. So I take a lot of pictures, document the entire case because there are things when the patient is on the chair, you have 10 things running on your head. Okay. And when you take a picture and you sit with the picture, you realize sometimes we just focus on the tooth without realizing the gingival zeniths are not at the same level or there's some gingival contouring to be done. You give the option to the patient. Agreeing to it or not is not in your hands, but you obviously give the option to the patient that there's something wrong. So the first step is analyze and evaluate the cause of the fracture, the history. Most of these cases are trauma cases. So history, vitality testing is a very important part of diagnosis. Then once we know we've eliminated all the causes, we know now the composite is going to last, then we go ahead and probably if the patient has some time, we take a impression or maybe a scan and try to do a mock-up. Sometimes when these patients come, it's usually in a hurry and they just want to get the tooth fixed. We fix it, like I would probably do a monoshade composite on it. I would have taken my scan and next day we call them for the actual composite layering because our layering would require putty index, everything. So doing everything in an emergency appointment is not possible. So we do a temporary solution for the patient, send them home, get our wax patterns, your max mock-ups done, and then we start with the putty index. Before we start, obviously the first thing is rubber dam isolation. Then there are different bevels that are given for different conditions, and then we start with layering. And then comes the most important part that most of us ignore is finishing and polishing. That is what we
Correct.
follow in my clinic.
Yeah. I think what you have correctly highlighted, that documentation is absolutely imperative because it helps you, always visit back as to what you have to get to and what you have to begin with. So yeah, it's very important for that one. Where you mentioned about isolation. Could you please highlight upon how important isolation is when it comes to composite fillings and their success?
I think without isolation, doing endo or composite is kind of not very ethical. According to I'm an endodontist, we obviously love isolations. So when I place an implant for when I'm doing a restoration or when I'm doing endo, it's such a beautiful field. There's no blood, there's no saliva, there's only tooth. It's one with the tooth. When I'm doing an implant, so there's a lot of blood and all. So, I mean, if I had an option, I would do an implant and then rubber dam isolation. That's what we consider. But yeah, all said and done, we are not realizing one thing that especially in our country, usually the cases which we get are not based only on enamel. Rarely you will get a case where you have only enamel bonding to be done. It's 99% you have your dentine with our books, with our knowledge, we all know that dentine is a very mischievous thing. So, to bonding to dentine is important. and very critical. So in such cases, if you have to deep bond to deep dentine or even regular dentine, isolation plays an important role. So there's this famous thing that Dr. Callan always say: we don't want to do saliva reinforced composite. We want to do composite. We don't want to do saliva reinforced composite.
That's true.
Yes,
So
that's
isolation is one of the very important part of our composite restorations. But can you also tell us what should be the understanding of etching and bonding for all the composite restorations?
Okay, so I have this simple protocol. Again, I'm a Gen Z, we don't like a lot of complicated things. So simple protocols according to what we follow, and it's all literature based. One thing, if I have enamel, it's only going to be etching and fifth generation bonding agent. If I have deep dentine, I would use a universal bonding agent, scrub the area, cure it. I'll do immediate dentine sealing. Once that is done, what is immediate dentine sealing? Universal bonding agent, seventh generation. What I prefer is, again, not sponsored by any company. What I prefer is Scotch Bond. That's by 3M. I apply it on the surface, I scrub it, I cure it. Then I use a flowable composite, preferably from the same company, apply it to the base layer in as thin as possible. Then I cure it. This creates a hybrid layer. Now you have to wait for something called as decoupling with time. This hybrid layer takes time to mature. So approximately, according to literature, 2 to 5 minutes is what you're supposed to wait after you are done with this layer. So once I'm done with this layer, if I have a class 2, I would probably start with my deep margin elevation. I'll not disturb this area, which is close to the pulp. I'll start on the next area. Now, if I have to wait for 5 minutes for anything in the mouth, again, rubber dam isolation is must. Else, you will have a saliva reinforced hybrid layer, which we don't want. Once your hybrid layer is secured, then I start with my etching. Then I whatever area is left, I etch it with our normal etching solution, then bonding, and then composite. So this is my protocol for deep dentine caries. In this, a lot of people ask that once you have sealed the dentine, you have a flowable composite layer, how can you etch it? So literature says you could do that because your deep dentine is now sealed. What you're dealing with is now your healthy dentine and your enamel. So which responds well to bonding.
That's very nice. So you have to say that post isolation, etching and bonding is important, and post etching and bonding, layering is a very
Yes.
important step that we all need to consider.
Yes.
yeah. And you just called it as a simple protocol. Interesting.
It is
Now,
simple for me. See,
moving on further.
there is no
Uh,
learning curve. So for me to say here, it's very easy because it has come over 7, 8 years of only doing composites for so many years. For implants, my mentor says the same thing to me, and I'm like, how? How is it simple? It's so difficult. It's so complicated. So I think there's a learning curve everywhere.
Absolutely, absolutely, rightly mentioned about that. Uh, Having said that, what do you think? How do you differentiate between an average composite and an excellently done composite? What is that one marking feature, if you could just say?
Okay, so there are two
Yeah.
things. One, if I have to immediately judge a composite, be it anterior or posterior, I'm not someone who would go immediately into how beautiful it looks because we are not social media dentists. We are here for patients. So the first thing that if my composite restoration does not have sensitivity, even for a day, that's a successful restoration. That's an immediate criteria. Second, when the patient comes to me after the third or fourth day, I don't see any yellow discoloration of composite. That's again a success for me, especially posterior composite, because anterior composite we obviously polish. When we talk about long-term success, when you have your patients come after, you have done a class 2, they come after 5 years, 6 years, and you take a IOPA, the contact is intact, that's a success. And obviously, when you see absence of any secondary decay, that's also a success. Wearing of composite is inevitable. If you see your composite, you have done a beautiful anatomy, and after 6 years, there's a wear pattern, that's completely fine because that's the normal wear pattern. Your enamel and dentine is also going to wear. So when I talk about success in composite, I divide it into two parts. Initial success, that is the immediate thing. You could have a beautiful looking composite. But after 2 years, when you see you have secondary decay, so what's the point?
True, true. So, as you said, we make a very beautiful composite restoration with all possible efforts, following all possible steps, and a flawless restoration. But after some time, over a period of time, you see that beauty has been lost. So, can you tell us? Can you highlight what goes wrong and where do we go wrong at this step, at this
Two
stage?
things. When I talk about anywhere about composite restoration, and I consult at a lot of clinics in Navi Mumbai, what I have seen is that we polish anterior composite like anything. Like we would use the best polishing agents, but when it comes about posterior composites, we just do the finishing and we just check the high point and like okay, done. So we are not polishing it. And the major reason, like after the patient comes after 3, 4 days for some other reason, you immediately see yellowish discoloration. Now there is one thing, composite does not know where it has been placed. Is it on the anterior tooth or it's in the posterior tooth? So why are we only polishing the anterior teeth? Why not posterior? The composite, if you've read the any company that you're using, you've read it. So all the companies suggest finishing and polishing because there's something called as oxygen inhibition layer. Even if you apply a layer of glycerine, you have these specks of composite hanging here and there in your class tooth. It's obviously going to accumulate plaque. So this is one thing we have to keep in mind. Irrespective of anterior or posterior, you have to polish your composite. Treat your posterior composites with respect, not just a cement material where you just put it and left it. Second biggest mistake is something I haven't spoken about yet is curing lights. We do not pay enough attention to curing lights. Most of us are using the curing lights that are given by the dental chair, which has absolutely no intensity. The thing is, we need at least 800 kilowatts for it to be cured. The best company curing lights, the ones that are above 1 lakh, also drop over time. The intensity drops. So how are you expecting your normal curing light for that is free with the chair that is going to last? So composite curing light is not when it becomes hard. You take your normal, I have a microscope, I keep my composite under microscope, it's going to become hard. But has it cured? Answer is no. So when you're buying a curing light, go for a reputed company. Now there's a new concept in composite curing lights where we also want purple curing lights. Most of our curing lights are blue curing lights. But now they are replacing camphoroquinone, that is a photo initiator, with another material because camphoroquinone leads to some yellowish discoloration over the time. So they are replacing this. So for that, because they have changed the photo initiators, in the future we would have composite that would require purple curing light. So Ivoclar is a company that has come up with a composite. So such cases, it's not that blue light is not going to cure them, but we need a mixture of blue and purple light. Third thing, when we are curing, so most of us, the curing light is with the assistant. We are doing somewhere else, we are working something else. The moment you look away, your assistant has moved the tooth. Or sometimes your assistant may not even know which tooth is actually being treated. So they would just cure it. So the composite on the surface would look hard, but you don't know what's underneath. And the last layer of composite is in contact with the tooth. So if that's not cured, that's going to create a problem. So finishing and polishing and reading a lot about investing in a curing light is the most important thing I would say in composite restoration.
Okay.
You rightly mentioned, we focus about bonding, we focus about the material use. But as you rightly mentioned about the post photo initiators being changed eventually and wanting a relevant light to it, I think that's where the theory part comes in. Knowing your materials, reading about what's there inside the new material that an MR is brought to you, their doorstep, and select light respectively. Very rightly mentioned. So, we often say that composite is more of an art, it's more of a science. So, how about a comment on that? Whether is it art or is it science? More of it.
I think for me, I'm not a very artistic person. Whatever I'm doing is completely based on science. I'm not a very good artist. My handwriting is horrible. My drawings also not very great. But I think once you know the science, the art follows. You can't be a very good artist. We are not here to do just mechanical work. As I said, my composite might look excellent, beautiful, but the patient is calling me next day, doc, what sensitivity hai. I failed. I failed as a dentist. I'm not here to create beautiful restoration. I'm here to create long lasting restoration. So for me, and I think most of my mentors, science is important. And once you know what I'm doing, what materials I'm using, art follows. That's, I think, the easy part. That's not very overwhelming. You might be, so sometimes when we look at a lot of photos from Instagram, we get disheartened. My composite is not as beautiful as the thing that is posted. But then no one posts their failures on Instagram. It's all the successful. Very rarely people are posting failures, and I really respect that because that humanizes them. It's not like none of my composites have failed. Obviously, things do fail. So when I talk about that, if you know why has something failed, it's more important than just randomly doing very good work. So for me, science is definitely more important. And once you are in that cycle of science, art follows. Then you just have to create a beautiful anatomy that comes with practice. You can't fast track that process.
Very well said, very well explained. All the steps, what has to be done. Now, can you please highlight what not to do? What are the top five mistakes you see dentists making in composite restoration?
Uh, Going ahead, straight to the case, kids get excited when they see an angle fracture without understanding anatomy. They go straight into their driving deep into the case, not checking the vitality before doing composite restoration. Your tooth might be non-vital. The patient will have pain and swelling the next day or probably after a month. Third thing, not doing rubber dam isolation. Fourth, finishing and polishing, not doing proper finishing and polishing. Fifth is, I think, curing light. So this is what the five mistakes that everyone does. Out of this, I think diagnosis is the most important part. If your diagnosis is correct, anything in dentistry, that be it FMRs, implants, composites, your veneers, everything is going to be spot on if your diagnosis is correct.
Very well said. Very, very well said. That brings us to you throwing some light on how important occlusion is for composite restoration.
So, as I said, I think we've spoken enough. I would just
Yeah.
now like to tell the steps what I do in my clinic. When the patients come with anything, class one, class two, a very important thing we don't know is pre-operative occlusion corrections. So, not maybe correction, just record. So, I take a 40 Bosch paper. Bosch is a company. 40 micron Bosch paper. I place it there and I check the pre-operative bite of the patient. So I know these are the points. Probably take a photo, you are not going to remember the points. So I take a photo, so I know this is my reference. Then I go ahead and do my composite restoration, keeping that photo at one place in my clinic where I can see it so that I don't end up accidentally creating a high point. And after my composite restoration, I check with the same 40 micron paper 40 micron paper, sorry. Then we check the occlusion and we check for any high points. So that's what I follow. And if it's a case where the patient has told me the angle fracture is chipping off again and again, we check the patient's excursive movements because if the patient is doing something like this or there's a parafunction, irrespective of how beautiful I'm doing my composite restoration, irrespective of how beautifully I've followed the protocol for bonding, it is going to fracture if the forces are more.
That's great, Shelly. Would your what would your roadmap look like for a dentist who wants to progress from basic to advanced composite dentistry? How would you go about?
So if I was to, this is how I started. So first thing, if you are still in college, if you are an intern or a final year, I know you're exposed to a lot of amalgams still, but try and watch if your seniors, your PGs are doing composite restoration, stand next to them. Probably if you're done with the case, ask them what shades, translucencies they have used. Second, start reading about different aspects of composite, as I said, etching, bonding, shades, translucencies. That's the theory part of it. Once you are out of college, then stick to one mentor, whatever you like. Stick to one mentor, someone who's teaching basics, not very beautiful and aesthetic restoration. You don't, at this point, you don't need very intensive courses because you will be overwhelmed with it. There is always a step. So you can learn your basic anatomy and your basic finishing and polishing protocols. Then you can move on to your next mentor. Meanwhile, what you have to do also is that whenever you have time in your clinic, take an extracted tooth and start practicing your carvings. So that is something, because you can rotate your extracted tooth. So you have to master that first, because in patient it's going to be more difficult. You can't rotate the patient. So it's very difficult to work on patients, but at least start somewhere. The best part about composite and even endodontics is that you can start practicing on an extracted teeth, unlike implants. You need patience to practice implants. How much are you going to drill in a jaw or whatever, a bone, something? So with composite restoration, that is one advantage. Another thing I would like to highlight is people say that for extracted teeth, the teeth are highly, whitish because it's dehydrated. But try to match that shade, because it's all about matching. You might have a patient that has fluorosis and has white teeth, has very opaque teeth. So you have to ultimately match it. So why not practice here? So learn your shade matching from extracted teeth.
Correct. Matching shade with the extracted tooth and also the patient's tooth in there. That brings me to you highlighting about photography in dentistry, especially when it comes to composite. So if you could just impress enough about the same.
So when I say I love photography, if you see my page, I like documenting cases. The simple reason is, first I have been liking photography before I joined dentistry, so that's just an added advantage. But after I joined dentistry, what I realized is there are cases that might look perfect to you on the chair, but once you document it, you might go home and realize that this line angle would have been better, this line angle thing should have been better. Second, if I've done a case today, especially someone who's starting their journey, you might do a case today, you would be very happy, you would post it on social media and everything. 6 months or 1 year down the line, when you see the case again, you would realize, no, it's not that good. So that itself is a very humbling process of, you are realizing that you have come so far. Something that you were proud of 6 months ago is not something you would do now. That happens with everything. That could happen with your veneer case as well. After 6, 8 months, you're like, no, this could have been better. Another thing, if you have a good mentor. So what I do when I was studying and now when I'm getting into implants, I document every case so that I can send it to them. So what that does is sometimes you miss out because you might not be aware about certain aspects, but your mentor is going to point out. The only way of communication is photographs. So I used to send my cases to my head of the department, Dr. Abrar, when I was in GDC. So next day we used to have this, just for 5 minutes, we used to have this case discussion. He used to tell me, okay, did you check the bite? Or the line angle should have been better. So that's where it becomes very important. And once you start documenting, you have this thing in the back of your mind that you are documenting it. So you automatically start doing good work because you're documenting it. The moment you leave your camera outside, you're like, हाँ ठीक है कौन देख रहा है चलता है. Especially in private practice, because in college obviously you have someone on your head who's going to look at it. But private practice, you need someone. So that camera is going to be your mentor. So okay, I have to do good work because I'm documenting it.
Very, very
Thank you
rightly
very
said,
much.
Shelly. So, what actually documentation and photography is going to help us evolve and our practice to evolve, right? So, Dr. Shaili, our listeners would also like to know: can a dentist actually build a practice around a composite restoration?
Yes, definitely. And not even in our country. There are so many international speakers who come to our country and they just teach composite. All they are doing in a day, they are doing maximum 4 to 5 composites. Again, all said and done, it's not easy because you are shifting from something that's you're going to a niche area. So if you are really passionate about composite, you could definitely do it. But of course, if you have that initial push of if you know 10 things, you can do this, that, whatever, and there are obviously consultants for everything now available. You could definitely develop or build a practice exclusively based on composite restoration, but the learning or the wait time would be a little more.
So now it was quite an interesting
One,
and
yeah, I think
yeah, I mean,
I had a network glitch in between. Sorry for that. Yeah. So one more thing. So once you set your practice around composite, what's the best way of communicating the value of composite dentistry to patients? I think earlier, as you mentioned, photography is one thing which, when you have your documented cases to show the befores and afters and how it can actually last and follow up pictures can help. Can you throw more light about the same? How you communicate the value of composite dentistry to patients?
So I think unlike like all fields of dentistry, it's now we have become to this thing of marketing yourself very well. So in a good way, in an ethical way, obviously. So rather than just saying that it's just a filling, you have to add value to the composite because it's going to change their life. Now, someone who has come with a deep class 2 and has been advised root canal and a crown or probably something like that, you just do a filling and they're happy. So that creates a value for the patient that they have saved so much. Root canal people just get panic. For us it's a regular thing. I might be doing 10, 12 root canals a day. For me it's a regular day. For them it would be the most scariest thing they have ever experienced in their life. So we forget, we don't have that empathy. So if you are saving someone's tooth, making someone's tooth vital, I'm not saying do heroistic dentistry where 100% there's a periapical lesion and everything you do a class tooth. Stupid. Don't do stupid or heroic dentistry. But what we are doing right now, if you're doing ethical practice and adding value to patients' life, you could definitely build upon composite. And I think this is there with all fields of dentistry. If you are adding value to the life, patient will value your efforts. Sometimes we also inform the patient that I'm doing a filling or a restoration. It may give you pain and we have to do a root canal. And patients do understand, at least the doctor is trying to take the efforts to save my tooth rather than just straight away choosing the doing root canal is the most predictable process. If you are an like for me, I'm an endodontist. I'm not scared of root canals. I'm kind of not very sure about a very deep class too, because we in endodontics we say pulp is a doomed organ. So we never know how it's going to react. Once the pulp is out, the procedure is 100% predictable.
great, great. So first we need to save the vital tooth. If it is not possible, then we go to the root canals, and
Yes,
everything has a life
of course.
expectancy, right? So quite an interesting and enlightening session for our viewers. Dr. Shelley, now let's close with a quick rapid fire.
Sure.
Okay, rubber dam or cotton roll?
Rubber.
Shade or shape? Which is more important?
I think shape.
One essential skill for beginners.
Rubber isolation and photography.
Okay. One skills that differentiate advanced composite dentist.
I think the knowledge about science.
One piece of advice for a dentist starting their composite journey.
Start reading about bonding more and translucencies. Don't forget about translucencies. Don't run behind shades.
Great, great. Last and the least, if you could leave dentist with just one message about composite dentistry, what would it be?
This is my advice to all. So be excited about what you are doing. It could be composite, it could be implants, it could be FMRs, it could be veneers, whatever you like. Just be excited of what you're doing. After a point, you will be a master at it. And when you are reaching that peak, maybe shift to something else that excites you. So 10 years down the line, my goal is to be as excited about dentistry as I am today. So I think that would be my advice. Do what you like. Be around people that are equally excited as you are. There are a lot of people who are depressed, tired, nahi dentistry mein scope nahi hai. Try to stay away from these people. There's a crazy lot of scope in dentistry. Just it's just that you have to understand and work hard. You don't need to be very talented. You just need to work hard and never stop studying. And always try and ask for help. There are amazing people out there who are going to help you. So that's my advice.
Thank you. Thank you, Shaili. Lovely session. And let's get back to you with the rubber dam workshops or a podcast on exclusive rubber dam.
Sure.
Thank you.
Thank you
Thank you.
so much.
Thank you
The
so much, Dr.
Dentistry
Shaili.
Channel, Bharat Dental Show, Dr. Amandeep and Dr. Khyati for this amazing opportunity. Special thanks to Dr. Saloni ma'am. Ma'am knows me since my UG days and she's been a mentor for me for almost, I think a decade now. So a big thank you to everyone who has shown the trust in me and given me this opportunity. Thank you so much.
Thank you.
Thank you for being here with us today.